I'm just gonna wait for everyone to trickle in. I know we had a number of people that, how do you say this, that registered. So I'm gonna wait for a bit. Okay. Okay. I guess we can start because I know your time is important. Okay. So, welcome. My name is Marivic. I am a counselor at AGI. For those who are joining us for the first time, here is a little background on us. Alzheimer Group is a charitable organization that supports families and individuals living with dementia. Our services include activities for people living with dementia, individual and family counseling, support groups for caregivers, and courses, workshops, and webinars such as this. Our educational initiatives are made possible by the generous support of the Lassner Learning Center in the Lindsay Memorial Foundation. Before we begin, please note that while the chat feature is unavailable, there is a Q&A space for you to ask your questions and leave your comments. You may type your questions at any time throughout the presentation, and we will try to address them when we can. So today we are pleased to welcome Dr. Julia Chabot. Did I pronounce it right?
Yes, you did.
Dr. Chabot is a geriatrician at St. Mary's Hospital Center since 2018 and is an associate professor in the Department of Medicine at McGill University. She completed her geriatric residency training at McGill, as well as a master's degree in psychology, research component at the University of Montreal. In the context of her master's degree, she completed a study on the effects of music on the health of hospitalized geriatric patients. She was program director for the geriatric residency training program at McGill for 6 years. In 2023, she became vice president of the Association of Geriatricians in the province of Quebec. She is also currently the medical coordinator for the Geriatrie Répondant project for the RUISS McGill. For several years, she has continued to unite her passions, music and geriatrics, through research. She is currently the co-primary investigator of a feasibility study using music-based virtual reality intervention on an acute inpatient geriatric unit. We would love to hear about this in the future, Dr. Chabot. Anyway, welcome, Dr. Chabot, and the floor is yours.
Perfect. Well, thank you so much. Thank you very much for this nice introduction, and thank you for this invitation. I'm very, very happy to be here today, and I'm even more excited to talk to you about our geriatric multidisciplinary team that we have in the emergency department at St. Mary's Hospital. I think this was a beautiful example of how working as a team can really, really make a huge impact in terms of care for our patients. So I'm going to start to share my slides, and hopefully everything is going to work very well. Perfect. So I'm going to go. So we're going to be talking, as I said, about the geriatric multidisciplinary team in the emergency department at St. Mary's Hospital. Before we get started, I just wanted to say that I don't have any conflicts of interest to declare about this presentation. The only thing is for the virtual reality music project, we did receive funding from the St. Mary's Hospital Foundation, but otherwise I don't have any financial support for this project. So, you know, in medical school and in medical residency training education, we often talk about the CAN meds, which are basically what are the basic skills that a physician needs. And so you see it's a little flower, and you can see the little petals. So it's kind of a nice image. And I think this geriatric multidisciplinary team in the emergency department is really a good example of a lot of those tools that we need to do when we're working as physicians, when we're taking care of patients. So the importance of communication, collaboration, importance of leadership and health advocacy, because it definitely took a lot of health advocacy to be able to get to where we are today. So I know that you do have access to the Q&A, and for those of you who are on a computer or on a phone and not traveling somewhere, but I'm just curious, before we kind of get started, I want to hear about your experience as visiting an emergency department, maybe as yourself, or maybe as a caregiver who went with their loved ones, or even maybe as a healthcare professional on the other side who's sending somebody in the emergency department. I'm curious to know what went well and what didn't go well with this. So if you want to put anything in the Q&A, were there complications during this stay? Was there more confusion? Did you feel like there was a good understanding of the condition of your loved one, or of your patient, for example? And I can see I'm not being very popular.
No, I think what I can do, I could share with you, Dr. Chabot, about some of the things that I heard from my caregivers.
Absolutely.
One of the things that they really are frustrated about is the lack of understanding of the staff within the emergency about dementia. And, you know, basically that's all the frustration they have. And also, I think, that's what they're really complaining about, and the lack of empathy as well. Like, you know, when in the emergency, because I think, you know, it could be a fast-paced environment, right? Like, I mean, really, I can just imagine. So I think that's where their frustration really coming in. Just like, yeah. Mm-hmm.
And that's very, very interesting. And that's one of the things we often hear from the other side often is, sometimes I hear families telling me, you know, I came with my father, for example, in the emergency department, but then it took me 2 weeks to recover from that 24 or 48 hours that they spent in the emergency department, because they were more confused after the emergency department visit, or they were deconditioned. They couldn't walk as much because they didn't walk during the time they were there. And it took them a little while to be able to recondition. The other thing that I hear also is, nothing was sent to my family physician, so nobody knows what happened or what was the plan, or the CLSC was never made aware, and maybe we needed more help, more services, or maybe there was a new diagnosis that was put in, and that could have changed the services that the CLSC is giving. So I'm giving you a very broad picture, obviously, but those are the things that were basically going through my mind in the emergency department, basically. So the goals basically for today, and I can see lack of a planned discharge. Definitely, there's often a lack of coordination. We see what's happening in the emergency department, but then when we leave the emergency department, we don't know what's going to happen afterwards. Perfect. So the objectives for the presentation today is I'm going to discuss a little bit about the approach that we have developed to the older adults in the emergency department, the role of our team, and you know, it's interesting because the other objective is to discuss about the importance of care transition, and that's really one of the big focus that we have with the team. So I work at St. Mary's Hospital, just like Marie-Vic was saying. In geriatrics, we're only 148 geriatricians right now in the province of Quebec. So there's definitely not a lot of us. We are fortunate to have 4 geriatricians working at St. Mary's Hospital, and we also have family medicine physicians, as well as care of the elderly physicians who did extra training basically in geriatrics, who are family physicians, who also work with us. And we have 2 wonderful nurse practitioners. We're very proud because we have the first 2 geriatric nurse practitioners at McGill. So we were very proud to be the first site to have that. So basically, this is a little bit of an idea about what our team does. We have a very full service in the sense that we do have an outpatient geriatric clinic. We have a hospital ward unit, and we have a huge presence, as I'm going to be discussing, in the emergency department. So we really try to organize our service where we are kind of meeting the entire continuum of care for our patients. So why a multidisciplinary team in the emergency department? So we already talked about that with hearing some of the experiences that some of the caregivers had shared, and some of the experiences that you have shared. But what's really important to keep in mind is that when you look at the emergency department visits, 20 to 40% of the emergency department visits in the province of Quebec are patients older than 65 years old. What's also interesting is that if you actually look at the number of patients who are hospitalized the vast majority are patients of 65 and older. So even if they are not the ones that are coming the most to the emergency department, they definitely are the ones that are the most likely to be hospitalized. So there's a complete inversion in terms of the ratio over here. And we also know that when we get older, there's often a lot of complexity. So there's the whole medical aspect, but there's often a lot of psychosocial aspect. Dementia, we talked about the lack of sometimes of understanding of dementia. So they might have cognitive needs that are also very different. They may also have a very, very long list of medications. So even something as simple as somebody is presenting with a pneumonia and they don't need to be hospitalized, but just all of the different medications that they're on might change my choice of antibiotics. So those are some of the particularities of the older adults. And what I always say is that geriatrics is a team sport. To be able to do geriatrics well, we have to work as a team. If we're just working alone in a silo, we're not going to give the best care for our patients. So the other thing to consider is that there are multiple risks of just coming to the emergency department. So what are some of those risks? So I'm going to go one by one. Medication mistakes or skip doses. So you can imagine if you're bringing if a daughter is bringing her mom or her dad to the emergency department, by the time they get seen, can we give the medication? Can we give the anticoagulant, the blood thinner medication, but they had a fall, they hit their head. The first thing we're going to do is we're going to say, hold this medication. Let's do the scan of their brain. We want to make sure there's no bleeding before we restart this. But often that can always lead to some delays in actually administering eventually the medication. Let's say the scan is normal and there's no bleeding inside the brain. So there's often medication mistakes that happen, or even sometimes medications that we give because we think it's the right thing to do, but where sometimes may not be the appropriate dose for an older adult, or may not be, and I'm sure sometimes I hear family members telling me, do not give morphine to my mom or my dad. And then my first question is, yes, how much of morphine did they get last time that they got? Because the odds are that the dose of morphine that I prescribe is probably very different than the dose of morphine than others prescribe. So those are some of the challenges just in terms of the medication. There's also a lot of patients who can develop delirium. So delirium meaning that people will get more confused. So sometimes just coming to the emergency department because we're bringing somebody from home or from their residence, they're changing their environment. Sometimes that is enough to make people more delirious. But then you can also imagine that you're in the emergency department, you're not moving as much as usual, you're probably getting a little bit constipated. Those are all things that can also make you more confused. Immobility. The rule of thumb that I often say is 1 day in bed means 3 days to be able to recover all of the muscle that you lost. So 1 day in bed is going to take you 3 days to go back to how you were before that event. So you can imagine that if somebody's spending 3 days on a stretcher or in a hospital bed without getting out of their bed, it's a week and a half of work ahead of us. So even if we think, oh, they're just there for a few hours, that can actually impact their mobility. Poor sleep. I don't know if any of you had tried to sleep in an emergency department. I remember as a kid going to the Emerge, and I remember trying to, I think I was 10 years old and I was trying to sleep, and I had this light right in front of my, like I couldn't get a minute of sleep. I was 10 years old. It was really not the end of the world. If anything, I think I was a bit happy to not sleep at night. But right now, any of us can imagine if we skip a night of sleep, we don't function as well the next day and the following days. There is also a lot of evidence associated with increased mortality. The longer you stay in the emergency department, there is an association with mortality because there could be consequences. And it's often associated also with an increased length of stay. So if somebody needs to be hospitalized, if they stay longer in the emergency department, the odds are that they're going to be longer in the hospital. We do know that. And I can see that somebody put in a comment saying that I'm surprised that my mother who has dementia is 99 years old, was sent unaccompanied in an ambulance by the seniors residence where she's on a secure floor to the emergency. So unfortunately, those are some of the things that do happen. And hopefully I'm going to convince you that the team that we have put in place in at St. Mary's is actually one of the things that we try to do to try to better to offer better care to our patients. So we came up basically with this idea, and I put the Back to the Future movie picture over there because we had an idea, but it's nothing new. It's something that actually has been described 20 years ago in the literature. But we said we need to find a way to better identify older adults in the emergency departments that are coming and who are at risk of having all of those outcomes that I talked to you about. All of those outcomes of staying longer in the emergency department, moving less, getting more confused, having medication mistakes, all of those things. We need to be able to identify them, because if we identify them early, maybe then we can change the trajectory. So I remember when I was in training, one of my staff used to tell me, Julia, your discharge planning, all of your coordination and everything starts the minute the patient enters the emergency department, not after 5, 6, 10 hours in the emergency department. The minute they came in, this is when you have to start to think about this. So we took that as a principle, and this is really one of our leading principles for our team. And I told you this is not something new. This is actually a study, if I'm not mistaken. This was in the early 2000s. They used a tool that was called ISAR. And what they showed is that if we're able to identify patients early, we are able to, the care that we're going to provide to those patients is going to be different, and we're going to improve their outcomes, basically. And it's funny because this actually was a big study that came out in the early 2000s, and St. Mary's Hospital was actually one of the sites that was part of the study. So I'm going to try to give you a case, and it's a very, very classic case of something that we can see in the emergency department. And we're going to do this case in 2023 at the beginning of the year, before we had a geriatric multidisciplinary team. And then we're going to go through the same case again, but with a multidisciplinary team, because I really want to give you, I feel like if I could give you all of the theory behind this, but I feel like if I give you a case, it's probably going to be much easier to understand what we're basically trying to achieve. So I'm going to try to walk you through this timeline. You have a patient who comes in at 6:30 in the morning. She lives alone at home, and she has left leg pain because she had a fall and she's not moving as well. We're 6:30. So she gets triaged and everything, put on a stretcher. At 9 o'clock, the emergency physician starts to see this patient and says, okay, we're going to order tests. He's looking to make sure there's no fracture. Obviously, there was a fall and there's left leg pain. So at 11 a.m., the x-rays of the patients are done. They're normal. There's no fracture. And the emergency physician is saying, you know, I'm not sure this patient is going to be able to go home. So we're going to ask the geriatrician to see her. So this is me coming in in 2023 without having a dedicated team to the emergency department. I come in more or less at 11:45. I start to do my consults, and I notice, you know, the left leg of the patient is really, really, really swollen. And I'm wondering, could there be a clot behind there? What we call sometimes a deep vein thrombosis, a DVT. So I order a test for this, and I say, you know, let's get the physiotherapist to come and see the patient, because I'm not sure this patient is walking that well. What we have to understand is that in that point, we're in 2023, I don't have the full dedicated geriatric multidisciplinary team. So for me to be able to get a physiotherapist, I had to call on a ward, and I had to ask the physiotherapist to come. So the physiotherapist basically left the ward uncovered so that they could come in the emergency department. And this is what she does. She comes at 1 p.m. and she says, I think your patient is going to be okay to go home, but she's going to need a cane. At 2 p.m., the patient goes for the test that I ordered, where I thought that there was a little bit more swelling on the left side. And at 3 p.m., I speak with the daughter. The daughter is telling me, you know, my mother has dementia. She's not good with her medication. She forgets to take her medications all the time. And she doesn't have any services. At 4 p.m., we find out that, you know, the suspicion that we had that maybe this patient had a clot in her leg is true. There is a clot in the leg. And now I'm thinking, I need to give a blood thinner to this patient. But now my problem is that this patient does not have any services at home. I know that this patient is not taking her medications on time. So I didn't have a choice. I had to admit this patient. So I kept her in the hospital. And eventually we coordinated everything with the CLSC, and we discharged her back home. So this is like the old model. But now let's think if we can identify, and I'm sure that there's a lot of caregivers that are here today and that are thinking, well, this patient, knowing that she had dementia, knowing that she was not taking her medication, the daughter definitely knew that the daughter knew that this was not going to be that easy to solve. So if we would have known this way earlier during the day, and if we would have started to work on these patients earlier, what could we have changed? And this is what I'm going to try to show you. So what if we try to identify the patient? I'm going to go back to this slide afterwards. So 7:30, our geriatric nurse comes in. She puts in a geriatric consult right away because she says, you know, this patient is living alone at home. She has dementia and everything. There's something let's tackle this. Let's tackle this case early on. And she says, we're going to ask the physiotherapist to see this patient if there's no fracture. But basically, she's already thinking this is somebody who's vulnerable. Then, instead of waiting for the emergency physician to see the patient, I'm also getting started as a geriatrician. I see this patient and I notice at 9 o'clock that the leg is more swollen. So we order the tests right away. At 10 a.m., we know that there's no fractures because the x-rays are negative. The physiotherapist walks with the patient, says she's going to need a cane. The daughter is contacted. We find out that she has dementia. We find out that she's not known to the CLSC. We find out that she's not taking her medications on time. So we say, let's get our occupational therapist on the case because maybe we can liaise her with some CLSC services. So at 10:30, our occupational therapist is on the case. And at 11, she's actually coordinating services. The patient goes for her test at 11 a.m. At 1 p.m., we find out that she has a clot. So when we know that she has a clot, we organize a follow-up with hematology, the treatment. The geriatric nurse calls the daughter, explains to her what is the plan, organizes a follow-up in hematology and everything. So at 3:30, we have a patient who's going home. And now we are coordinating the care. So the discharge medications are being sent to the CLSC, being sent to the pharmacy. The patient is given a cane. We're not just prescribing, we're giving her a cane when she leaves. We referred her to the CLSC. We have insurance that the CLSC is coming in the next day because this is urgent. We booked a follow-up in hematology. The daughter is called. The daughter knows when the appointment is in hematology. And we have a happy patient and a happy daughter who are leaving the emergency department. So we managed to avoid a hospitalization by working as a team. This is basically how, like in a nutshell, this is how we function as a team. And I forgot on the previous slide, I wanted to show you this. Sorry. But all of this is actually possible because the St. Mary's Hospital Foundation believed in this project. So what happened is that when we were seeing all of the difficulties that we had in the emergency department with the care of older adults, we went to the St. Mary's Foundation and they were incredibly generous because they accepted to fund our team for 2 years. They did accept to fund the team for 2 years. And over the last few months, we've actually been collecting information, which I'm going to share with you to demonstrate that our team is actually working. Okay, I'm going to go back to the next slide. Okay, so this is a nice picture of our team. So this is Zev. Zev is our social worker. This is me, but it's not always me who's in the emergency department because it depends on the day. Sometimes it's my colleagues, obviously. This is Natalie, who's our physiotherapist. Stephanie, our occupational therapist. This is Lisa, who's our geriatric nurse. And this is one of our residents who rotated with us because part of our mission is also to expose residents and medical students to how it is to work as a multidisciplinary team. How is it to work as a team together, to collaborate, communicate, and everything. So this is basically our team: geriatrician, nurse, physiotherapist, occupational therapist, and social worker. We really work as an interdisciplinary team where we all come in with our little expertise. And this way, we're really able to have a 360 view of the patients. We're really able to have a holistic approach. And we really want to facilitate all of the continuity of care, coordination of services. And we also want to see sometimes, can we avoid a hospitalization? Sometimes we can't. There will still be patients who will need to be hospitalized, that's for sure. But even there, all of the work that we've done in the emergency department before the patient goes up, we make sure that we call the units, give them a summary, inform them about the case. And you can imagine that they start to take over the patient with much more information. So it's facilitating a lot of things, obviously. Perfect. Oh, and we have Zev's wife. Oh, Zev is fantastic. Very, very lucky to have him. The goal of the geriatric multidisciplinary team, as I said, so we're really trying to work as a team to address all of those complex needs. We want to optimize the hospital admissions and sometimes think about, is there a solution? Could we avoid somebody coming in the hospital? And we really want to make sure that there's a lot of work that's being put in the care transition. So in terms of the roles of each member, and I'm sure you can understand now with the example, but the geriatrician is really there in terms of the medical role. So like in this case, this patient had a clot, so we're evaluating the patient, finding out there's something with this leg, what's going on. So this is really the role of the geriatrician. The nurse is very, very proactive in being able to screen patients, being able to identify patients when they come to the emergency team. She's really our team leader. She's the one who's leading all of our discussions. She's looking from a nursing angles, what are going to be the nursing care of the patient. So she'll collect some information. Our physiotherapist will definitely focus on in terms of mobility, the safety assessment. Our occupational therapist focuses on what is the function of the patient. If we send this patient home, is this patient going to be able to take a shower on their own? Is this patient going to be able to cook for themselves? Is this patient, and is it safe? If we're talking about somebody with dementia or major neurocognitive disorder, is this patient, do we think that it's safe for this patient to be cooking, for example? So all of those things. And our social worker is really there. We're seeing a lot of complex psychosocial cases, more and more. And having this expertise to kind of put the entire picture together. And what's really, really important for me is that when we assess a patient, everybody's role is incredibly important. Because even for me, if I say, I diagnose that this patient has a clot, my treatment is that she needs to be anticoagulated. But if I don't know, well, this patient is having this patient doesn't have services, for example, at home, and we're worried about the fact that she's going to skip medications. If I don't have that information, even if I've done the right diagnosis, even if I prescribe the right treatment, if the right treatment doesn't get to the patient, it's not going to work. So the medical management is not going to work. But to be able to find that, it's incredibly nice when we're able to find that out as a team, obviously. We also have intervenants réseau that are working with us, and especially at St. Mary's Hospital, we are in a territory we're in the Jewish hospital territory of care, but we're with another CIUS. So it is a little bit more challenging because we're not in the physical location of our own CIUS. So it's really nice to be able to have intervenants réseau that are able to help us out and liaise also with the CLSC teams. And all of us together are going to be liaising with home care services, getting collateral information. And one of the things we want to try to work on is that if the nurse is calling the daughter, then I might not need to call the daughter afterwards. Like the daughter might not need to get 4 phone calls, because if the nurse is afterwards relaying the information, and this is something that we hear a lot from caregivers. Sometimes they say, do you know how many times I've repeated the same story? And I'm tired of repeating the same story again and again and again. But because we're working as a team, hopefully we're not calling, hopefully we don't keep asking all of the same questions. What is our typical day in the geriatric emergency department? So 7:15, our nurse comes in. So she's here bright and early, and she starts to review some of the patient's charts. So she'll flag some of the charts. So the minute somebody is 75 and older, she'll go through the chart. We do a Prisma. Prisma is a score that basically tells us if somebody is vulnerable, at high risk in terms of functional decline. So the minute they score 4 and higher, she also will look at the chart. So already at 7:15, she's already starting to screen and trying to identify which patients. And sometimes there are patients, because it's not just about age, but we might have somebody who's 85 years old and who is coming in with something, but might not need to be necessarily seen by the multidisciplinary team. So that's why this importance of the screen is so important right from the get-go, because we want to be as efficient as possible. So we really want to be able to identify who's going to benefit the most from us. But there are some patients who might not necessarily need to be seen by the physiotherapist, the occupational therapist. It really depends. At 8 a.m., the nurse actually goes to sign over. So sign over is basically when the emergency physician who did the night will transfer all of the cases to the emergency physician who's starting during the daytime. So she goes to this moment. And what's really nice is that because she's been there since 7:15, sometimes she actually gathered information that she can share with them. But sometimes they also will give her information. So it's kind of a communication that goes both ways. So she gathers all of that information, and then she makes up a list of, here's the list of patients that we need to focus on for today. And then at 8:30, we meet as a team. So everybody is here. PT, OT, social worker, nurse, and geriatrician, medical students, residents, we're all together in the same room. We're very efficient, 15 minutes. Like it's like we don't spend too much time together. And we identify who needs to be seen by who. And then this is where we decide maybe this patient needs to be seen by a geriatrician or doesn't, or maybe this one just needs to be seen by the physiotherapist, or maybe what this patient needs is the social worker and there's nothing medical, so the geriatrician doesn't need to get involved. And we kind of divide the cases amongst ourselves to try to be as efficient as possible. And it's not just about efficiency, it's also to give the right service to the right patient, obviously. At 9 o'clock, we basically all get to work. And we meet again at 11:30. We do have another very quick 15 minutes where we go through this list again, and then we say, well, who's done what? Where are we at with this patient? And sometimes the physiotherapist might tell me, Julia, I saw this patient. We were hoping that they would be able to go home, but their gait is not at baseline. They will not be able to manage at home. So you have to see, and it's going to be an admission. So then I go and I see this patient. Or she may have told me the opposite and may have said, I'm going to speak with the emergency physician. I don't think the occupational therapist or the nurse needs to get involved. The mobility is basically back to baseline and we're good to go. So this is where we discuss our cases. And then at 1 p.m. until the rest of the day, we kind of cycle through this. So we tackle new consults. We continue to discuss informally. It does happen sometimes that we have complicated cases where we say, okay, let's organize another short meeting to discuss. So that does happen. And we basically finish the consult. The team is only there during the daytime from Monday to Friday. My dream is one day to have it 7/7. So 7 days out of 7, that would be wonderful. We're not there yet, but at least we're there from Monday to Friday. We unfortunately don't have anybody overnight or late in the evenings, as you can imagine. But this is where we started from. So I wanted to show you some very, very basic statistics without going into too much detail, because that's not, sometimes I don't want to bore anybody. It's really not my point. But basically so what we did is that we analyzed the charts of patients. We analyzed our visits from January to June 2023 and 2024. So you're kind of getting measures of a half year of work. And what's important over here is that they're both the same period of the year. As you can imagine, the reason for presentation in January is very different than the usual presentation maybe in the summer. We get much more falls in the winter when people are slipping on ice. So in 2023, there were more or less 400 patients that were seen by the geriatrician in the emergency department. But you can see over those 6 months. But you can see that in 2024, we increased this to 613. So working as a team together definitely is helping us to increase this capacity to see more patients, as we can all imagine. You can see that the patients that we're seeing are quite old. We're talking about 85 years old on average. Most are women, so in both groups, about 68%. Most of them are from home or from an RPA. They are also moderately frail. So this is a clinical frailty scale, which is a scale out of 9. So 5.3 and 5.4, it means that they are moderately frail. So we're seeing frail older adults. And the Charlson is basically an indicator of how many diseases that they have. So they're very, very complex medically, those patients. So 6 and 5.9 are pretty high numbers. So this is what we've had. And we've also, you can see that now that we have a dedicated geriatric team, It's much easier to get the physiotherapists involved without having to steal them from another ward, for example. So 40% of the time the physio would get involved, but now it's more than 50%. Only 12% of the time we would steal a physio, an occupational therapist to come on in the emergency department. Now that we have somebody who's dedicated, it's 36% of the time. Our social worker is also we're keeping our social worker very busy with all of our complex cases. And obviously, I mean, I don't necessarily, as a geriatrician, see every single patient. So we see more or less 80% of the patients, because there's a 20% of the patients that don't necessarily need to be seen by a physician. And obviously, before the team, we did not have a nurse, and now she's seeing about 50%. She screens everybody, but she doesn't necessarily see everybody, because again, it depends on what the needs are. So we actually had very, very nice results, because what we noticed is that the length of stay in the emergency department decreased by 11.5 hours. So basically, on average in 2023, those patients were spending 38.8 hours in the emerge. Now they're spending 27.7. I'm not saying that spending more than 24 hours in the emergency department is good. That's really not what I'm saying. But it was really, really nice to see that we managed to decrease that length of stay by 11.5 hours. And I think the key behind this is that because we identify them early, we're able to prevent the complications that can happen in the emergency department. We also significantly decreased our number of admissions. So you can see in 2023, 73% of the patients that were seen by the geriatrician needed to be hospitalized, and now it's 56%. So we decreased our admission by 16.1% actually. The length of stay also in the hospital, and I'm going to talk to you about that a little bit later on, also has decreased by about 7 days. So I think because we get to work very early on, even if they're being admitted, and because we communicate with the team upstairs, we're able to get the hospitalization more efficient. After 7 days, because the other thing is, okay, it's very nice, you're seeing all of those patients, you're sending more home, but do they bounce back in the emergency department? Not within 7 days. It's the same, 2.8 versus 4.5%. It's not considered significant. It is, however, we do, and I'm going to show you a graph a little bit later. I think we do have a little bit more 30-day post return to the emergency department, but I'm going to show you another graph to better explain that. So a picture is worth 1,000 words, but basically I'm going to show you those statistics, but in a longitudinal way, so over time. So this is the length of stay in the emergency department. So the point CA, this line over here, is when our multi-D started, and this is time. So this part over here is before we had the team, and this is now that we have a team in place. So before having a team in place, we were seeing this is the length of stay basically slowly declining. But look, the minute the team started, it breaks, and then it really becomes much more steep. So that's the 11.5 hours of decrease in length of stay. So I think we really, really did a lot of work in this. The rates of admissions, that's interesting because this is January to June, and again, January to June, but a year later. So it looks like in the summer, we tend to admit more in both cases, but definitely overall, you see that we're admitting much less since we have the team. The length of stay in the hospital, again, this is before the intervention, and this is since we have the geriatric multidisciplinary team into place. So we really, really had a steep decline. The return to the ED, so coming back after, if somebody's getting discharged from the emergency department, are they coming back within the next 7 days? They're not really coming back within 7 days, not more than what we had before. What's interesting is this 30-day. This graph is not as pretty as our other graph, as you can see, because this is before the intervention. And it's interesting because it looks like in January and February, people tend to come back more within 30 days than the rest of the season. I think when we started the team, you can see that we had much more, but then over time, I think we're decreasing. So I'm actually wondering if we're learning more to work as a team. So we'll see in the next few months how this graph is going to evolve. But I have to be very honest, when we look at the results, we did have a little bit more patients coming back after 30 days. I mean, we could twist it different ways. I used to have a physician when I was in training who would tell me, but we managed to keep people outside of the hospital, even if it was for 2 weeks. Listen, they were home for 2 weeks. Maybe it was better than if they would have stayed in the hospital. Who knows? But I think there's definitely part over here that's been that there's a learning effect, that we're getting better at learning what to do with patients. So I'm just going to wrap up in the next few slides because I want to leave some time for questions or discussion. But the Canadian Association of Emergency Physicians created a position statement of how can we better equip basically our emergency department for older adults. And they did do some recommendations, and I wanted to show you what we've been able to do. So the first thing is they want to make sure we recognize that older adults is a departmental priority. It definitely is. We also want to have an interdisciplinary assessment of complex older adults, which we definitely have. We also want to involve family members, caregiver in the care, which is definitely something we do every single day. We want to prioritize training and education of emergency department staff. Mary Vic, you were saying at the beginning that sometimes the caregivers were saying that they felt like the team were not equipped to deal with dementia, did not understand necessarily what dementia was. I'm going to show you what we did, but we actually created a lot of teaching modules for our team. And I can see somebody put something. I think I'm gonna take that question a little bit later if that's okay. The other thing is that developing standardized approach to common geriatric presentations. We are, it's not in the order, I'm sorry. We are slowly working on this. Equipment to modify the space to support the needs of older adults. We are in the process of doing this. Ensuring high quality transitions of care. We're working on this. And having quality indicators, which is literally the numbers that I just showed you about the care of older adults, just to be able to monitor over time, how are we doing basically with the patient. So this has been very nice for us, because if I go back to before we had the geriatric multidisciplinary team, we definitely were not meeting all of those statements. And even at the beginning of the geriatric multidisciplinary team, we did a lot of work to be able to fulfill those statements. What are we currently working on? We are applying to become a geriatric-friendly emergency department. There's different levels. It's given by the American College of Emergency Physicians. We're going for the lowest level, which is bronze level, but we're already thinking about the silver level. So we sent our application a couple of weeks ago. We probably will be hearing back in the fall. So we're very much looking forward to hearing this. The other thing that we're doing also is that we're distributing little pamphlets to family members, caregivers, patients, to get their feedback on their experience by having been seen by a member of the geriatric multidisciplinary team. So that we can collect more information and have a better idea also how we can continue to improve. We are also in the process, a part of the application for the geriatric friendly emergency department, we needed to demonstrate that we always have food available for our patients in the emergency department to prevent denutrition and things like that. So our fridge is always full, and we always have little snacks and collation basically for our patients. And by the way, it's not rare. Sometimes we'll discharge our patients at, let's say, 5 p.m. and they live in a residence, and we're worried that they're going to skip the meal. So we make them a little lunch bag before they leave. So at least we know they're going to have a lunch bag and they're going to eat. So it's little details like that, but do make a big difference, obviously, as we can imagine. We also created this section with walkers and canes, so that anybody who's coming in the emergency department, we don't have to try to beg to find a walker. We have enough walkers for everybody who needs a walker, basically, or a cane in the emergency department. We also created a lot of teaching modules for the personnel, for the staff working in the emergency department. So I just put 2 of those over here, but it gives you a bit of an idea. We tried to make them pretty so that people would be interested to read them. But one of the things is we want to minimize the use of catheters for the urine. We know that we tend to overuse them, and it's associated with infection. And it's also associated, I don't know if anybody had a catheter, but if you're hooked onto things, it's really hard to move. And we know that if people are not moving, they're deconditioning, and it's harder to get them home. So it's all a vicious circle. So we actually created online modules and those little summary things. We have multiple QR codes in the emergency department where people can refer. We also have those posters everywhere in the emergency department. This one is to minimize NPO status. NPO is nilperos. So basically when patients are not allowed to eat. Sometimes we don't have a choice. If somebody's waiting for surgery, of course they cannot eat. But sometimes we have a tendency, we have to question ourselves, well, do I really need, can this patient eat? So we're trying to minimize this process. So we're asking for the nurses to reassess this every 4 hours, etc. Oh, sorry, this is a duplicate. I'm just gonna move this one very quickly. So in conclusion, as you saw with the numbers, our multidisciplinary geriatric team in the emergency department really had an impact in terms of fluidity in our emergency department. But not only did it have an impact on fluidity, because those are numbers, obviously, but we actually are providing the right care for the right patients at the right time. And I think this is by far the most important thing that we've accomplished. And what's also been very nice is that I told you that the St. Mary's Foundation has been extremely supportive and gave us funding for the first 2 years, but coming up with those numbers and demonstrating how well our team was working, the CIUS, so the administration said, okay, we're going to make this team permanent, obviously. This is us. This is a cute little picture of our team celebrating our first year, and our team makes the best potlucks, by the way. We love that. I'm happy to answer any questions. As Marie-Vic was, I don't know, Marie-Vic, if you mentioned, but we've actually been fortunate. We had a couple of opportunities in terms of media coverage over the last year. So it's been really nice for us to be able to share some of the wonderful work that our team has done. And thank you. I'm going to stop sharing and I'm happy to take questions.
Okay, I think I have one question right now, and I think this is, yeah. So what is the usual protocol for seniors, residences to send elderly dementia patients to emergency? Is it typical for them to be sent unaccompanied in an ambulance? Is it typical for them to be returned to the residence by medical taxi, I suppose? Who supervises and monitors the wanderers like my mom in emergency? So
it's a bit of it's a very complicated question to answer, to be honest. So I'm going to try to take one question at a time. What is the usual protocol for seniors residents to send elderly dementia patients to the emergency department? I think it really depends on every resident. So there's no, I can't say, oh, there's a specific protocol that they have to follow up. So it really depends on the residents. It depends on the resources of the residents. You know, there are some residents that don't have medical coverage, others that do. So I really cannot answer that question. It's too heterogeneous. Is it typical for them to send unaccompanied in an ambulance? I guess to send patients to the emergency department in an ambulance. I don't work in the ambulance setting, so I don't know, to be very honest. I know that ambulances are limited with who they can bring inside the ambulance, however, and I'm not sure they would have space to have somebody else. But I'm not sure if I'm fully answering this because it's really out of my scope of practice. Is it typical for patients to be returned back in a medi-taxi? So often when we choose how patients are going to go back to where they live, home or residence, I mean, often it's either if there's a family member who comes and picks them up, otherwise it's the transport médical. It's very rare that people are being sent accompanied by somebody. If they are, it's often if there's a medical need, actually, well, if there's a medical need, they're not going to go back to the residence.
No.
But it's very rare that they're going to be sent with somebody. Who supervises and monitors the patients wandering in the emergency department? It's kind of everybody's responsibility in the emergency department. I think one of the things that we try to do is that we know at St. Mary's that there are some sections in the emergency department that are maybe easier for those patients where they have a little bit more room where they can move. So that's one of the things that we'll try to do. Like I'm thinking in my stretcher number like 22, 21, I know is definitely easier. So we'll try to move them to those to those sections exactly. But it's not, and the problem is that our emergency departments are really made, you know, for this classic, this person comes in with one problem and we address the one problem and they go home. The problem is that we're now coming in with an aging population who's coming in with rarely just one problem. And if it's just one problem, it interferes with 5 other problems. So it's the entire model that has to be reseen. But it is a challenging thing that we have. By the way, in terms of wandering behavior and behavioral issues, I didn't show you, but this is also another teaching module that we gave, where we're saying, you know, if somebody, for example, is physically or verbally agitated, first of all, are all of their needs met? Is it because they need to go to the bathroom? Is it because they're in pain? Is it because, so we're doing a lot of training with the teams right now. So every nurse had to do an online module. We have those posters, reminders. I think having the presence of the geriatric multidisciplinary team really, really helps. But yeah, it's a lot of work.
Yeah. So first, Dr. Chabot, thank you very much for your presentation. I'm just listening, and as you said, you're following all those criteria that were that how it should be for older adults in the emergency, and just to hear you say that you are addressing all of those, because those are the things that most of the families actually are complaining about, like length of stay in the emergency is just too long, even after that hospitalization as well, right? Like, I mean, and I know that you're trying to, how do you say this, to shorten those stays because they're the most vulnerable, and in the emergency is, I feel like it's a melting pot of all those diseases, and they're already vulnerable. So they may come for one reason, but if they stay longer, they may end up like, you know.
Exactly.
So it's just to hear that is really reassuring, that, you know, you have such a team that really focuses on our older adults. You might be inundated now with so, but and then we're hoping that, like, you know, that you're gonna be there 7 days,
we're hoping
7 days a week. Yeah. So anyway, so that was my question, just like, what do you do for because I know most of our families, at least for the families that I know, they send their loved ones when they are, sometimes, you know, with dementia and with UTI and infection, they really manifest with a lot of agitated behaviors, right? So what do you do when they present them to you in the emergency? What kind of interventions do you, like, I mean, can you walk us through that? Like, I think that is the thing that I would be really interested in.
So I mean, what we try to teach the teams, because what we have to understand is that we have a geriatric nurse, but she's not the nurse of the patient in the emergency department. Like, she's with our geriatric team. So what we're trying to do is that we're training the teams also in the emergency department. So to be able to care for those patients. So we created an online module where we're explaining what's the best approach and all of those non-pharmacological management that we do for people with dementia. And that's why I was giving the example a little bit earlier, that the first reflex should not be somebody is agitated, let's put restraints. The first reflex should not be somebody is agitated, let's give them a medication to calm them down. The first reflex should be, is there a reason why they are agitated at this point? Is it because their bladder is full and they need to go to the bathroom? Is it because they're severely constipated and they're having pain? Is it because, so that's one of the things we really, really are doing. And we're trying to teach the teams to do and to incorporate into their practice, basically. There will be times, unfortunately, where we don't have a choice. Well, we will have to use medications, we will have to use restraints. But if we do, then our principle is always try to be the least restrictive possible. So as an example, instead of using physical restraints over the wrists and over the legs, can we get a geriatric chair and sit this patient in a geriatric chair? Because it's much less invasive, as you can imagine. And if we do have to give a medication, well, let's get the lowest possible dose. But this is really, if everything else that we didn't work, then we go with this. It's really a last resort.
Okay, so what you're trying to say is you're trying non-pharmacological
Absolutely. Yeah.
approaches before
Yeah.
you resort to
Yeah.
restraint and medication. You mentioned about the geriatric chair. I can't really picture how it is.
Ah,
Can you describe it for me, for us, please?
c'est un peu un fauteuil. It's like a chair, but there's a little table incorporated in the
Oh,
chair. So
okay.
basically, when somebody is seated, they have a table. It's kind of a way. So if we have somebody who's wondering, for example, if there's an obstacle in front of them, it's harder for them.
Them
So,
too.
and it's much better, as you can imagine. And even sometimes we just do that with just our little hospital tables with the little wheels. So sometimes that's enough. Sometimes you just put them in a chair and we put the table in front of them. And that's enough to kind of limit, not necessarily for everybody, but it's all of those approaches sometimes that might help.
Okay. Okay. Sounds really, like reassuring. So, yeah. So, I have another question, but it slipped my mind.
It's okay.
Anyway, is there, if Dr. Chabot, if our clients, let's say they have questions after this, can we email you our
Absolutely.
questions if there
Yeah,
is?
absolutely.
Okay. Okay. Thank you very much. Well,
Oh, and I think, Marie-Vic, was there somebody who had their hand up
no, I
also?
think you addressed it. It's about the restraint and
Okay.
aggression. I think that was the last question. Yeah, is the use of restraint being used for people with dementia who can be aggressive, which we know, if they are in a state of extreme agitation, right, and they have this delirious and they have infection.
Yeah.
Most likely their comprehension is low and they're not going to be understanding more. So if you so anyway,
Sounds good.
yeah. Anyway, thank you very much, Dr. Chabot. And we are looking forward to hearing more from you, hopefully in the future with your studies about music as well. Anyway, thank you very much for giving us the time today.
You're very welcome. Have a good afternoon, everybody.
Yes.
Bye-bye.
Bye-bye.